Welcome back to The Explainer. So today we're diving into a really massive shift in modern healthcare, which is figuring out how to properly bill for digital, non-face-to-face patient care. Because look, if you work in a medical practice, you already know patient care doesn't just happen in the exam room anymore, right? It happens on our screens, it happens through patient portals, and it happens over the phone. But actually capturing the revenue for that very real, very hard work, well, that requires navigating a pretty strict maze of coding rules. So today, we're going to master the framework and the guardrails for online, digital EM services and virtual check-ins. Let's get into it.
Okay, so here's our quick roadmap for today. We're going to look at the overall digital encounter landscape, break down e-visits and those 7-day tiers, look at virtual check-in mechanics, map out some very strict timing and bundling rules, and finally, figure out how to avoid the top audit triggers.
All right, starting right off with Section 1, the digital encounter landscape. So the reality of healthcare today is that your patients are just constantly reaching out. They're messaging through secure EHR portals, they're uploading photos of rashes, asking all sorts of follow-up questions. And to actually get paid for the time you spend managing all this, you need to bill an online digital EM service, what we usually just call an e-visit. But to qualify for this, there are 4 absolute mandatory prerequisites. First up, the communication has to be asynchronous. That just means it's not a real-time live chat or phone call. Second, it has to be patient-initiated. The patient literally has to be the one reaching out to you first about an acute or chronic problem. Third, it has to happen through a secure platform, like your EHR's Patient Portal. And fourth, and hey, this is a really big one, it is strictly reserved for established patients. There is absolutely no way you can bill an e-visit for someone who is brand new to your practice.
Now, taking a look at this AMA CPT table, it brilliantly illustrates exactly how these services are officially categorized. Notice how online digital EM sits distinctly apart from your synchronous audio-video visits or your standard audio-only phone calls. It's got its own dedicated framework. It specifically notes that the time is accumulated over a 7-day period, which is completely separate from your typical same-day EM visits. Really, understanding this categorization is kind of your foundational map for compliant billing.
Moving right along to Section 2, e-visits and 7-day tiers.
Okay, so when we talk about digital EM codes, your whole mindset around time calculation needs to completely shift away from standard office visits. We are no longer looking at an isolated single encounter. The absolute crucial point here is this number, 7. For e-visits, time is summed up over a strict 7-day cumulative window. The clock literally starts ticking the exact moment the provider conducts their initial review of that patient's digital inquiry. So every single bit of professional decision-making, chart review, assessment, and any back-and-forth portal communication related to that specific issue over the next 7 days, all of that gets added together into one cumulative time pool.
And here is exactly how that cumulative time translates into actionable codes. Notice that we have 2 totally distinct pathways here. Over on the left, you've got the codes for physicians and qualified health professionals, basically the folks who can independently bill EM services. If your cumulative time over those 7 days is 5 to 10 minutes, you're reporting 99421. 11 to 20 minutes, that's 99422, and 21 minutes or more is going to be 99423. But take a look at the right column. If this digital assessment is actually being managed by non-physician clinical staff who can't independently bill EM, think physical therapists or speech-language pathologists, you've got to use the 98970 series instead, which matches up with those exact same time thresholds.
Which brings us to Section 3, virtual check-in code mechanics. Now, these check-ins operate on a totally different mechanical framework compared to the e-visits we just talked about. They are highly targeted. Let's compare 2 major HCPCS codes to help build out your toolkit. Up top, we have G2012. This is a brief, synchronous, meaning real-time communication. Usually it's a quick 5 to 10 minute phone call that is again initiated by an established patient. The whole goal of G2012 is simply triage. The provider is just trying to determine, hey, does this patient actually need to come in for a full visit? Versus G2010 down the bottom. This is your classic store and forward service. Say an established patient takes a photo of a weird wound, or maybe a video of a tremor. They send it in, and the provider evaluates it and gets back to them within 24 business hours. Again, this is a highly specific digital service with distinct criteria that separate it from your standard 7-day portal messaging.
All right, let's look at Section 4, strict timing and bundling rules.
As powerful as these digital codes are, I have to warn you, we are now entering the rigid danger zones of exclusionary billing. This timeline perfectly visualizes the exact chronological boundaries that you have to navigate. Imagine you are sitting right in the middle at current time, trying to bill your digital encounter.
You absolutely must look backward into the look-back exclusion zone, and you also have to look forward into the forward-looking bundling zone. If your digital service bumps into either of these zones, it is highly, highly likely you are not going to be able to bill for it. So let's break those specific zones down.
First up is the 7-day look-back rule. This states that you literally cannot separately bill for an online digital e-visit or a virtual check-in if the inquiry relates to an E&M service that was provided within the previous 7 days. Think of it like this. If you just saw a patient in the office on Tuesday for hypertension, and then on Friday they send you a portal message asking about a side effect from the new blood pressure med you just prescribed, well, that portal time is considered part of the previous encounter's management. It's completely bundled. There is just no way you can bill a new e-visit for it.
And then we have the forward-looking exclusion, which is the 24-hour next step rule. Let's say a patient messages you, and the provider looks at it and thinks, actually, you know what? This sounds pretty serious. You need to come into the clinic today or tomorrow. If that happens, you cannot build a digital code. If your digital triage results in an in-person EM visit or procedure within 24 hours, or even at the soonest available appointment, the effort of that digital triage is simply absorbed right into the payment for the subsequent in-person visit. You just bill for the in-person visit, and you drop the digital code entirely.
Finally, Section 5, avoiding top audit triggers.
You know, understanding all these rules is one thing, but actually proving you followed them to an auditor, that's a whole different ballgame. Auditors are looking for major red flags right out of the gate. First up, billing for new patient. Like we established earlier, these codes are for established patients only, period. Second, provider-initiated portal blasts. Let's say your clinic sends out an automated message to 100 patients reminding them to get their flu shot, and a patient replies. You cannot turn that reply into an e-visit. The patient has to be the one initiating the clinical inquiry. Third, billing for administrative tasks. Routine stuff like prescription refill requests or scheduling an appointment, well, those just don't require medical decision-making, so they absolutely do not qualify for e-visit billing. And finally, honestly, the most common error we see, failing to explicitly document the cumulative time the provider actually spent managing the issue right there in the EHR.
Taking a look at this compliance checklist, which is pulled straight from our source guidelines, it highlights telehealth, sure, but these foundational principles apply across all digital encounters. Explicit documentation is simply non-negotiable. You have got to document patient consent. You have to document the specific technology or platform you used, and, most critically for our cumulative codes, your documentation must clearly, unmistakably state the total time spent over those 7 days or detail the specific medical decision-making. You know the golden rule. If it's not in the chart, you didn't do it.
So I want to leave you with this final, provocative thought to take back to your practice. Pull a few of your recently billed e-visits and really ask yourself, does your EHR documentation truly support the cumulative time you are billing? Are your start and stop times actually clear? Are you maybe accidentally bundling administrative tasks into clinical time? Doing a proactive internal audit today is without a doubt your absolute best defense against external audits tomorrow. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.